Okay, so we are to the T and M staging, one of the most important part of the diagnosis and staging. Okay, so T, excuse me. So T is for tumor, N is for lymph node, and M for metastasis. So T, there will be TX to node to IS to 1 to 4, and then same N and X where the lymph nodes cannot be assessed, and 0 non-lymph nodes, metastasis, and 1, and then there will be subgrouping 2A, 2B, 2C, and then 3, and then M0 and M1 is for mets. Let's see what T says. TX, X mean unknown. Unknown means primary tumor cannot be assessed. Cannot be assessed. And then if there is T0, that means the no evidence of tumor. It does not mean that there is no tumor, but there is no actual evidence of tumor according to TNM staging. Thus, there is no size, there is no mass, there is no irregularity, there is no ulcer which looks like mass. Okay, T0. So, for example, you have an ulcer and indurated and granular, and take a biopsy, and in biopsy you did not see the islands or worlds of those cells, and then you'll see there is no or squamous cell carcinoma, so no evidence of tumor will be this. And then TIS, IS means in situ. So tumor in situ or carcinoma in situ means that it has not crossed the connective tissue basement membrane. T1 to T4 are the tumor stages, the mass according to the size. For example, if the tumor is less than or equal to 2 centimeter in greatest dimension. What do you mean by greatest dimension? It means if it's like this size. So if you see this length and this width, the width is smaller and the length is a little bit greater, right? So you see the greatest at the greatest dimension, either it could be length or breadth or width, depending on the greatest dimension, you will see the size of the tumor, and if it's equal to 2 centimeter or less than 2 centimeter is T1. The tumor is T1. The region is T1. And if it is between 2 centimeter and 4 centimeter, it is T2 stage. The tumor is at T2. And if it's more than 4 centimeter, then T3. So 2 to 4 centimeter is the boundary. Between 2 to 4 centimeter is T2, less than 2 centimeter, T1, more than 4 centimeter, T3. And T4, of course, the last stage always is like extension. What do you mean by extension? When it invades or invasive tumor, the last stage is always invasive T, where it invades adjacent structures, go beyond the oral cavity margin, which includes mandible invasion, bone invasion, tongue musculature, muscles of the tongue, extrinsic, intrinsic, maxillary sinuses, and then skin. If these are involved, adjacent structures are involved, if there is invasion, then there is the last stage T4. Same is the case for the lymph nodes. And if there is an X, it means cannot be assessed, is unknown status of regional lymph nodes. We do not know, we cannot assess the lymph nodes. Somehow we cannot assess. And then T node or T0 means no regional lymph node metastasis. The cancer cells, the malignant cells has not been reached to the lymph nodes. And then N1 means single ipsilateral lymph nodes, and the lymph node, you have two sides, yeah, two sides of a face. And then there are cervical lymph nodes, and if you cut them in a half, base for the node, and if one node involved, and on one side single ipsilateral node is less than or equal to 3 centimeter is N1, one lymph node, and 2 divided into A, B, and C, where A will be like N1, single ipsilateral, but the size will be more than 3 centimeter up to 6 centimeter. Whereas 2B will be multiple ipsilateral lymph nodes with size greater than 6 centimeter. So not only single change to multiple while going to 2A to 2B, but the size also greater than 6 centimeter, not like 3 to 6 centimeter. And C is now bilateral. So up to 2B, 2A, everything was ipsilateral, and now we have bilateral or contralateral. Ipsilateral mean towards the one side. If the lesion is in the eye and on the right side of the lymph nodes, we say these lesion, two lesions are ipsilateral. But if we say one is here and one is here, it's contralateral or bilateral. So how to remember? N1 single ipsilateral and 2A also single ipsilateral. 2A is closer to 1 as compared to 2B and 2C. So both of them are ipsilateral, but the change is, so it's single lymph node and ipsilateral on the one side, single lymph node ipsilateral. So the change is in the size. Here it is less than or equal to 3 centimeter, but there it is 3 to 6 centimeter. Like here it was 2 to 4 and more than 4. Here is 3 to 6 and more than 6. So N1 is single ipsilateral and 2A is single ipsilateral. The size is different, less than 3 centimeter, and 1 and more than 3 to less than 6 centimeter is 2A. And now 2B will be multiple, but still ipsilateral on the one side of the face. Multiple lymph nodes, but ipsilateral on the one side, but greater than 6 centimeter. The size is always getting more. But 2C is closer to 2B in the terms of size. The size in 2B and 2C will be more than 6 centimeter of the lymph nodes. The lymph node gets enlarged. Lymph node enlargement is known as lymphadenopathy. Lymphadenopathy. The lymphadenopathy, the lymph enlargement is more than 6 centimeter in 2B and 2C. So what is the difference in 2B and 2C? One is multiple ipsilateral, one is multiple bilateral. The size is more than 6 centimeter in both 2B and 2C. Okay. And N3 is the largest, where metastasis in all the lymph nodes with more than 6 centimeter, and it's bilateral and multiple lymph nodes are involved, and all of them are more than 6 centimeter. Now, this is a very invasive and horrible picture for this oral cell carcinoma, squamous cell carcinoma. And then M0 is when there is no distant metastasis, and when there is M1 distant metastasis. Where can it be? BLL, BLLB, bone, liver, lung, brain. These are the 4 sites for the secondary tumor development or metastasis we have studied for oral squamous cell carcinomas. Okay, so now after this TNM staging, we have stage grouping where we say TN, T1, N1, M0. If T1 means there is less than 2 centimeter tumor, and then one lymph node is involved, TN is like single ipsilateral lymph node less than 3 centimeter, then we say it's stage 1. And then stage 2 is T2, N0, M0, M0, N0, and stage 3 have 2, T3, N0, M0, or T1 or T2, like this. And then stage 4 is T3, N1, M0, T4, any T with N2. So up to here, it was N node. Up to stage 3, it was N node and M node. But stage 4, we got N1, N1, N2, or maybe N3. So stage 1 to 3, how to remember it is, for example, T1. So we have N node, N node, N node. Okay, let's light it clearly. Okay. So we have N node, N node, N node, M node, M node, M node, right? So if stage T1, stage 1, T2, N node, M node, stage 2, T3, N node, M node, stage 1, stage 3. Or maybe T1 or T2 with N1 or M node is also stage 3. This is the extent. But then T3 from T3 with N1, or T4 with N0, or T2 with N2, when the lymph nodes are more enlarged, then the stage 4, with the last being M1. When M is 1, when there is metastasis, it does not matter what is T, what is N, because it must be the last stage of the last stage. So when there is metastasis or METs, M1 is there, not M0. We don't care that it can be any T, T1, T2, T3, T4, or any N, N1, N2, A2, B2, C, or 3. If there is M1, this is the last and the least and the poorest prognostic stage and the most horrible picture for that cancer, where there is M1. We don't take care of what is T or N. It's the last stage of cancer. So this is TNM staging with stage grouping for OSCC, oral squamous cell carcinoma. So there is a summary for what is oral cell cancer and what can I do. What is oral cancer? Cancer is a disease where cells in the body grow out of control. You know cancer, right? Where the cells proliferate in an unordered manner and a lot out of control. Oral cancer is a disease where cancer cells form in the mouth, lips, cheek, gums, tongue, hard palate, tonsils, and the throat. These are the places, common sites, but still 4 are the most common: lateral tip of the tongue, lateral aspect of the tongue, or ventrolateral, hard palate, buccal mucosa, and lips. Okay, then what can I do? What can I do? What you can do is avoid commercial tobacco, either smoking or chewing. Smoking or chewing. Tobacco exposes the mouth to cancer-causing chemicals, carcinogens. Limit alcohol use or don't use alcohol at all. Alcohol can cause cancer by damaging DNA. Get vaccinated against HPV. Why HPV vaccination? Because HPV was one of the factors or cause or etiology for oral squamous cell carcinomas. HPV, human papillomavirus, infects oral cells. HPV often has no symptoms, is asymptomatic. Vaccinating is essential. Hep B, other than Hep B, HPV, we should get a vaccination. And then limit sun exposure. Why limit sun exposure? Because UV radiation can cause lip cancer. Remember, lip cancer. Sun exposure can cause lip cancer. Use a lip balm with sunscreen to protect your lips from harmful sun exposure. Maintain healthy weight and be active. Poor diet, lack of exercise, and poor oral hygiene can make it easier to develop oral cancers. So these are the steps you can take care to avoid oral cancers. Now we go for the last part of this slide and stomatology, that is treatment of OSCC. Oral squamous cell carcinoma, OSCC, currently is treated largely by surgery and or irradiation, radiotherapy, and chemotherapy. So we have some therapy and some invasive therapy. Invasive therapy is surgery, and then other therapy includes irradiation, radiotherapy, and chemotherapy. Let's see how surgical care is done in this case. Surgery is performed. The goal of surgery for oral squamous cell carcinoma is to remove the primary tumor together with the margins of clinically normal tissues to ensure complex excision of malignant tissues. So what is the goal of the surgery? To remove the oral squamous cell carcinoma from the primary tumor along with the margins of the normal tissues. So for example, if you have a tumor here, you go beyond 1 centimeter margin and you remove some of the normal tissue along with the cancerous lesion to make sure all the malignant tissue has been excised, to ensure the complete excision of malignant tissues. Those people who are sleeping, wake up. You need to go. So if this is the tumor, if this is irregular tumor, you can excise 1 centimeter beyond the tumor margin along with the normal tissue to make sure the tumor has completely excised. Ablative surgery like electrocautery, ablative surgery, where you use some electricity to burn the tissue. Ideally excises cancer. Ablative surgery, also laser surgery is also ablative surgery, or carbon dioxide surgery also ablative surgery. Excise cancer. Excise means cuts cancers with at least a 2 centimeter margin of clinically normal tissue. If at least one lymph node has clinical signs of invasion, so if there is at least N1, a reasonable presumption is that others may be involved. So if there is N1, at least one ipsilateral lymph nodes is involved. So the presumption of doctors or physicians is that maybe other lymph nodes are also involved. So that's why traditionally we also perform a radical neck dissection. Whenever you see radical word with any surgery, you just think that lymph nodes, the local lymph node, the regional lymph nodes are also removed. Radical mastectomy, radical neck dissection of lymph nodes along with the OSCC, because we found T1N1 M node. So we are suspicious the lymph nodes involved. If one lymph node is involved, others may be involved, and then we need to perform a radical neck dissection of OSCC, oral squamous cell carcinoma. Functional neck dissection. What do you mean by functional neck dissection? To preserve the function. Okay. Modified to preserve the sternomastoid, accessory nerve, internal jugular vein. SAJ. Sternomastoid muscle, accessory nerve, and jugular vein, internal jugular vein. If we preserve them, we do not remove them somehow, then we say this is a functional neck dissection because the neck is still functional, while ensuring complete removal of involved nodes have gained popularity. So this functional neck dissection, where what happens is you preserve three structures. What are those? Sternomastoid, accessory nerve, and internal jugular vein. Yes. When these are preserved, this is known as functional neck dissection, right? This is becoming okay. So this has become famous, gain popularity, and this become famous procedure for this OSCC of the oral cavity, of the oral squamous cell carcinoma of the oral cavity. Now we go to the radiotherapy. We have advantages and disadvantages of radiotherapy. What are those? So advantages, when there is normal anatomy and functions are maintained. So when we use radiotherapy, radiations, and then the advantages are that when you use a radiotherapy, the normal anatomy and functions are maintained. Unlike surgery, because when we perform surgery, we excise tissues, surrounding tissues, to avoid the invasion. So we cannot preserve the anatomy of the structure. But radiotherapy preserves the anatomy of the structure, and hence when the anatomy is preserved, the function is preserved. And general anesthesia is not needed, as in the case of surgery. To perform surgery, we need some general anesthesia or local anesthesia. But for radiotherapy, the advantages are the normal anatomy and function are maintained because we are not removing any anatomical structure, and general anesthesia is not required, as in the case of surgical care, it is required. What are the disadvantages? Adverse effects are common. The radiotherapy has some of the adverse effects. Cure is uncommon. Cure is uncertain. We are not sure the radiotherapy will help us in the treatment. Sometimes it does, sometimes it doesn't, especially for large tumors and invasive tumors. And subsequent surgery is more difficult and hazardous, and survival is further reduced. So in some cases, when you perform radiotherapy, it gives more time for the tumors to get enlarged, If you remember, hepatocellular carcinoma is 1 week, it is 10 centimeter. In the second week, if you have not performed surgery, it becomes 20 centimeter. Invasive, aggressive, rapid. Some cancers are also rapid. So if you are getting radiotherapy for like 1 to 2 weeks or 3 to 4 weeks or months or 2 months, that will give some time for that aggressive tumor to become moderate to large. And then when it becomes moderate to large in size, then the surgery performed after radiotherapy will be difficult because the tumor has grown in size and the survival is reduced. Further, the mortality increase. Post-op morbidity also increase. Post-operative morbidity also increase. Gee. So now these are some of the cases you see here. Pre-laser stage 4 tongue carcinoma. This is the stage 4 tongue carcinoma lump. And after 2 weeks of the removal, it looks like thick. After 4 weeks, it looks like thick. And after 8 weeks of laser with chemotherapy and SATCON, there is some fibrosis in this area, lateral aspect of tongue. And it looks like it's almost gone with only this area remaining. And this reticular fibrosis is there. And then there is another example where pre-laser carcinoma, tongue stage 4. Stage 4 means T and at least 2, T4 and nod, T3 and 2, or T2 or 1 and 2 or 3. At least N2, right? Or N1 with T4, stage 4 carcinoma. So post laser, 2 weeks after removal of this laser surgery, and post laser 4 months, and you see there is fibrosis and almost the lesion is gone. And then the lesion looks almost gone there. There is no other than local fibrosis, and there is no lesion seen. After 6 months, no sign of cancer. So it has some benefit. Complications of radiotherapy, we will see that there can be oral mucositis, there can be dental problem. Oral mucositis can be most distressing. Oral mucositis, in oral cavity, mucus will be involved, inflamed because of the radiation. Now we are studying after radiotherapy what can be the complications. Oral mucositis can be the most distressing and maybe a significant effect on the quality of life. Very important question for the exam. As many as 40% of patients can be affected. So after radiotherapy, there can be oral mucous membrane inflammation. What is the treatment? We give polymyxin E, tobramycin are applied as an ointment locally for 4 times daily. Oral hygiene should be maintained by brushing the teeth and rinsing the mouth. Advise the patient to eat soft, bland diet, not spicy, not oily, bland, not spicy, not oily, bland, and soft, and avoid irritants such as smoking, spirits, alcohol, spicy foods, oily foods, chewing tobacco, areca nut. Topical analgesics, for example, aspirin, benzamine, lignocaine, local anesthesia, diclonine, maybe provide symptomatic relief. So you need topical analgesics. I still remember the lignocaine is given, lidocaine is given as a gel while you intubate some patient. You can also use low potency or over the counter lidocaine gels or these topical analgesics. Diphenhydramine, and then there is chlorhexidine. You can use as gargles. You know gargles? Yes. Topical chlorhexidine, gluconate, and sucralfate may reduce the frequency and severity of mucositis. So you can gargle with these. Dental problems can be there. Patient who undergo cancer therapy may be predisposed to caries because of the hyposalivation, because of the mouth cancers, food with high sucrose content, and possibly a shift to more carcinogenic oral microflora. That can be a complication of radiotherapy. Radiotherapy will decrease the saliva of the mouth, in the mouth. It will cause dryness of the mouth. And when there is dryness, there will be some other dental problems like caries. Dietary control and topical fluoride, like found in the toothpaste therapy, are essential, must be continued for life. Toothpaste, brush your teeth. Patients Dryness of mouth, again, salivary tissues, particularly serous SNI, eyes are highly vulnerable to radiation damage. So when you apply radiotherapy, the serous SNI of the salivary tissues, salivary glands are damaged, and parotid glands are damaged most readily. When they are damaged, there will be hyposalivation, less saliva will form, which leads to discomfort and loss of taste and appetite. What is the treatment of this? In hyposalivation, residual salivary tissue may be stimulated by gustatory or pharmacological stimuli. You can give some medication to induce salivation in your salivary tissues. Sugar-free chewing, when you chew, it will create some saliva, which will stimulate some saliva, is an inexpensive way for this and has no adverse effect. Inexpensive way for the dryness of mouth, the treatment. Sugar-free gums are also given to the diabetic patients when they feel dryness in mouth. Okay, pilocarpine, as tablets, is effective in relieving symptoms and is improving salivation when used in the dose up to 5 milligrams administered 3 times daily. Longer term complications of radiotherapy, loss of taste, because you see hypersalivation leads to discomfort and loss of taste and appetite. The same loss of taste. Osteoradionecrosis, less commonly of the necrosis of the bone due to radiotherapy. Osteoradionecrosis is less common, and other problems also may be distressing. Long-term complication of radiotherapy, when you use the radiotherapy for long term, and then after chronic, there are some complications, chronic complications. Radiotherapy also complicates further surgery. As you remember, during radiotherapy, the tumor is still growing, and if radiotherapy is not effective, the tumor has grown in the size, and now the surgery is difficult. Because in particular, endarteritis decreases the healing of the wound. It is very good. Endarteritis, you remember the arteries at the end, the loop arteries in the bones, those are end arteries, and then the inflammation of those end arteries will cause endarteritis, and it will decrease the healing of the wound. So these are the complications of radiotherapy. So today we finish our stomatology. I hope you have learned a lot. I hope you have learned something new regarding your anatomy of the oral cavity, and then the lesions, the dental caries, and all of that, the muscles from the nerves, and then we studied periodontal diseases. So